with the idea of trying to have some semblance that we're staying on time, we'll do the second section of the motor disorders. And our next speaker will be Stuart Speckler, talking about mucosal defense and eosinophils and esophageal disease. It's always a pleasure for me to introduce Stu because he's a long-term friend for about 40 years, trained in Boston, been down in Texas at UT Southwestern VA, and now at Baylor. At Baylor, he's head of the GI division, and Stu is involved. We know him in Barrett's esophagus, but more recently he's gotten involved with eosinophilic esophagitis. So Stu, always great.
Thank you, Joel. It really is a great pleasure to be here today, have a live conference like this, and then to hear Steve DeMeester tell us that nobody needs anti-reflux surgery. Oh my gosh, it's amazing. Okay. If I can get this to work, it'll be even better. Okay, there we go. Okay, so let me tell you about this 29-year-old man who had heartburn and dysphagia. He was treated empirically with PPIs because they thought he had GERD, but his symptoms improved only very slightly. So he had an endoscopy. PPIs weren't stopped, even though they hadn't done much to help his symptoms. And the endoscopist found normal appearing esophageal mucosa with normal esophageal biopsies, no eosinophils. Okay, he then had a manometry that suggested a diagnosis of achalasia, had 100% failed peristalsis. IRP was at the upper limits of normal. When I finally saw him, I got this atopic history of asthma, seasonal allergies, so I really started to think about eosinophilic esophagitis. So we stopped the PPIs and we repeated the endoscopy 4 weeks later. And now, off PPIs, he had florid EOE with esophageal furrows and rings and an esophageal biopsy showing more than 50 eosinophils per high-power field. And we published this case primarily to make the point that an endoscopy performed with a patient on PPIs cannot rule out eosinophilic esophagitis. And that really shouldn't have been a surprising finding, because PPIs are used to treat EOE, and about half the time patients respond. But many physicians still don't stop PPIs routinely before they perform diagnostic endoscopy. If you don't, and EOE is in your differential diagnosis, you really should stop them before you do the endoscopy. You can't rule out EOE in a patient who's taking PPIs. But what about this motility problem? So did this patient just happen to have two unrelated diseases, or might there be a connection between EOE and achalasia? Now, these two disorders would seem to have very little in common. EOE is an allergen-driven condition. We recognize it by mucosal manifestations, whereas achalasia is an esophageal motility disorder. We recognize it by esophageal muscle dysfunction. But this is really a superficial way of looking at these disorders. We think of EOE as a mucosal disease because the mucosa is the only part of the esophagus that we can see and sample endoscopically. But in the rare circumstances, when pathologists have had the opportunity to examine esophagectomy specimens from EOE patients, they found eosinophils infiltrating all layers of the esophageal wall, including the muscularis propria. And when pathologists have examined the esophageal muscle from achalasia patients, they've often found eosinophils also infiltrating the muscularis propria. Now, our current concept holds that achalasia is not primarily a muscle disease, but rather it's a disease of the neurons that innervate the esophageal muscle. For unclear reason, neurons in the esophageal myenteric plexus disappear, and that's thought to impair peristalsis in the body of the esophagus. And then the loss of inhibitory neurons to the LES impairs its relaxation with swallowing. Now, where did this notion come from? Well, the notion that achalasia is caused by destruction of esophageal neurons was first proposed in 1930 in a report by Sir Arthur Hurst, who was the founder of the British Society of Gastroenterology. In that report, Hurst described postmortem exams of the esophagus of 8 patients who had end-stage achalasia, and he concluded that the fact of greatest importance was the disappearance of all ganglion cells. And over the years, Hurst's concept has been refined into our prevailing concept, which holds that achalasia is an autoimmune disease targeted at esophageal neurons. Now, recent study has found that achalasia in young people is associated with atopy as often as it's associated with autoimmunity. This was a population-based retrospective cohort study. It assessed associations between achalasia and atopic disease, autoimmune disease, and neurodegenerative disease. The database included almost 2,600 patients with achalasia matched to 10,400 controls, and it turns out that the achalasia cohort was less likely to have a neurodegenerative disease, which was present in 1.6% of the achalasia patients, 2.4% of controls, the adjusted odds ratio of 0.57. Now, in agreement with earlier studies, the achalasia cohort was 39% more likely to have autoimmune disease. But the achalasia cohort of patients under the age of 40 was also significantly more likely to have atopic disease, like asthma, eczema, allergic rhinitis, with an adjusted odds ratio of 1.4. So the association of atopy with achalasia was as strong as the association with autoimmune disease, and the authors concluded that this suggests an atopic etiology of achalasia for younger patients. Now, even before we knew there was a disease called eosinophilic esophagitis, there were reports of esophageal eosinophilia being associated with achalasia. In 1989, investigators found immunohistochemical staining for eosinophil cationic protein in biopsies of esophageal muscularis propria taken during Heller myotomy in all 9 of 9 patients with idiopathic achalasia. In a 1994 study of esophagectomy specimens from 42 patients with end-stage achalasia, investigators at University of Michigan found that all of them had eosinophils and lymphocytes infiltrating the myenteric plexus, and more than half had eosinophils infiltrating the muscularis propria. And more recently, a study of esophageal muscle biopsies taken during POEM from 28 patients with achalasia found that 86% had immunoreactivity for eosinophil major basic protein and eosinophil-derived neurotoxin. In 2018, Vani Kanda, Ron D'Souza, and I proposed some potential mechanisms to explain an association of achalasia and eosinophilia. One potential mechanism was that esophageal eosinophils might cause achalasia-like motility abnormalities by releasing myoactive or neuroactive secretory products that disrupt peristalsis and interfere with LES relaxation, and activated eosinophils release a plethora of myoactive and neuroactive substances that can have profound effects on esophageal muscle. We also proposed that esophageal eosinophilia might actually cause the neuronal destruction of achalasia by releasing pro-inflammatory and cytotoxic eosinophil secretory products, and activated eosinophils release a number of cytotoxic proteins that are perfectly capable of killing neurons. And there's strong evidence that esophageal eosinophilia can cause reversible motility abnormalities, and there are reports describing normalization of esophageal motility in patients whose esophageal eosinophilia was treated with steroids. For example, this motility tracing is from a 22-year-old man with dysphagia who had an esophageal biopsy showing more than 50 eosinophils per high-power field, and it shows the absent peristalsis and poor LES relaxation characteristic of achalasia. After treatment with steroids that corrected his eosinophilia, his dysphagia disappeared, and his motility study documented the return of peristalsis and improved LES relaxation. Now, reports like this suggest that eosinophils in the esophagus can cause reversible esophageal motility abnormalities, including those of achalasia. And I think this is compelling evidence that achalasia can be caused by eosinophilic esophagitis. And these data are very difficult to reconcile with the notion that achalasia always is the result of the destruction of neurons in the myenteric plexus. I mean, is there any neurodegenerative disease for which steroid treatment causes dead neurons to regenerate? So here's the hypothesis we proposed in 2018. Just like eosinophilic esophagitis, EOE can have mucosal predominant and muscle predominant forms, and muscle predominant EOE can underlie the achalasia and other esophageal motility disorders. In support of the hypothesis, we cited data showing that eosinophils have multiple secretory products that can relax or contract esophageal muscle. We cited reports documenting normalization of achalasia motility abnormalities with treatments that got rid of the eosinophils. We discussed how eosinophils secrete proteins capable of killing neurons, and we discussed how eosinophils have been found frequently in esophageal muscle of patients with achalasia and other motility disorders, even when there were no mucosal eosinophils. These data suggested that achalasia might develop from a muscle-predominant form of EOE. And this recent study of high-resolution manometry findings in 109 consecutive EOE patients from Dr. Guali's group, it confirms that achalasia occurs frequently in EOE. Achalasia was found in 8 of these 109 EOE patients. And another 8 had obstructive motility disorders, including 5 with EGJ outflow obstruction, which often is an achalasia variant. Now, we've been talking exclusively about eosinophils, but evidence has been accumulating recently that mast cells also play a very important role in the eosinophilic gastrointestinal disorders, the so-called EGIDs. Mast cells are immune cells that arise from the bone marrow. They circulate, then differentiate after they migrate into different tissues. They play a major role in initiating inflammation and repair in response to numerous tissue insults, but they're best known for the prominent role that they play in allergic diseases. Now, mast cells are not easily identified on H&E stains. But if we routinely did special stains for mast cells, like immunohistochemical staining for tryptase, then we might have called eosinophilic esophagitis mast cell esophagitis, because mast cells often outnumber the eosinophils in this disease. And just like eosinophils, mast cells are little toxin factories that make a number of pro-inflammatory, myoactive, neuroactive, and cytotoxic products. So all of the arguments that we just discussed for how eosinophils in esophageal muscle might cause achalasia also pertain to mast cells. Now, my Center for Esophageal Diseases recently undertook a study to explore our hypothesis that achalasia might be an EGID, an eosinophilic GI disorder. Our surgeons took LES muscle biopsies during Heller myotomy from 10 achalasia patients and 3 patients with outflow obstruction, 7 men, 6 women, median age 59. For controls, we had LES biopsies taken from 7 heart-beating deceased organ donors who had no evidence of esophageal disease, including 4 men, 3 women, median age 42. Now, the LES muscle was stained with H&E to look for eosinophils and immunostained for tryptase to look for mast cells. And we also evaluated the LES muscle by PCR for genes mediating smooth muscle calcium handling and contraction. Now, we started this study specifically to look for eosinophils in the LES muscle, and we didn't find them. Most of our patients and controls had no eosinophils in their LES muscle, and those who did had them only in low numbers. Now, I can't explain the disparity between our study and other studies that found increased eosinophils in achalasia. Perhaps it's related to the fact that most of these patients were taking PPIs at the time they had their myotomy, but we really don't know. Tryptase immunostaining showed that unlike eosinophils, mast cells are plentiful in LES muscle, but They were no more plentiful in the patients than in our organ donor controls. But where we found striking differences between the patients and controls was in the degree of mast cell degranulation. This panel A shows tryptase stain of LES muscle in an organ donor control. You can see that there's lots of mast cells, but they're all intact. In contrast, look at the profound mast cell degranulation that we found in our achalasia patients with all these little mast cell granules in the paramecium between muscle bundles. And this slide shows nerves in the myenteric plexus. This panel is from an organ donor control, and you can see there's a couple of intact mast cells surrounding this nerve bundle. But in this panel B from the achalasia patient, you can see the profound mast cell degranulation involving this nerve bundle. In every case, the difference between patients and controls was this striking. Now, my old good friend and mentor, Don Costell, used to say that a representative sample is the best one we ever saw, but this really is representative of what we saw. These patients with achalasia had this profound mast cell degranulation in LES muscle. Now, we also did PCR for mRNA expression for a panel of genes involved in smooth muscle calcium handling and contraction. On this heat map of gene expression in individual patients, red colors mean upregulation, bluer colors mean downregulation. And hierarchical clustering analysis showed 2 mototype gene expression patterns in LES muscle. All of the type 2 achalasia patients clustered in this mototype 2, in which there was upregulation of 3 calcium handling genes and upregulation of 4 smooth muscle contractility genes. In contrast, the achalasia 1 and 3 patients clustered in mototype 1, and they exhibited upregulation of 3 different calcium handling genes, namely ORI1, ORI3, and STIM1. We concluded that LES muscle of patients with achalasia and outflow obstruction shows striking mast cell degranulation. Now, this finding supports, but it certainly doesn't prove our hypothesis that achalasia might be allergy-driven. We also found that patients with different achalasia manometric phenotypes show different LES patterns of expression for genes mediating calcium handling and muscle contraction. So in other words, there are differences in the muscle gene expression of patients with different achalasia manometric phenotypes. So here, in conclusion, is the latest iteration of our hypothesis, that there is a form of achalasia caused by activated eosinophils and/or mast cells in esophageal muscle. According to this hypothesis, it's the neuroactive and myoactive eosinophil and mast cell products in muscle that cause the motility disturbances of achalasia. This hypothesis is strongly supported by reports of achalasia-like motility disturbances in EOE patients resolving with steroids, and very difficult to reconcile with the concept that achalasia is a neurodegenerative disorder. When patients with achalasia when patients with EGIDs acquire this EGID-mediated form of achalasia, their genetic mototype might determine the resulting manometric phenotype. And finally, the ganglion cell destruction that you find in late-stage achalasia may not represent a primary pathogenic event, but the late-stage collateral damage inflicted by the chronic release of cytotoxic and pro-inflammatory cytokines from eosinophils or mast cells. I think there's no question that achalasia can be an EGID manifestation. What remains to be shown is how often that actually happens. Is this very common, or is it just unusual? But I think in the not-too-distant future that our achalasia patients might be wearing this T-shirt. And I thank you very much for your attention. Stay up here. Okay.
Thank you, Dr. Speckler, for that insightful talk. It's wonderful to be here for an in-person AFS meeting and to be surrounded by thought leaders in the field of esophageal diseases. On that note, it's my pleasure to introduce our next speaker, who's definitely a thought leader in this field, a distinguished clinician, educator, and researcher, Dr. Phil Katz. He is just a few blocks uptown from us, from NYU. He is the director of motility lab at Weill Cornell, New York Presbyterian. He served as the chairman of gastroenterology at Albert Einstein Medical Center in Philadelphia and professor of medicine at Thomas Jefferson. He's going to be talking to us today about the clinical spectrum of achalasia. Dr. Katz.
Go get him, Phil.
Thank you, Tanuja, Joel, Stuart, your usual fantastic talk. And we at Cornell look forward to helping you prove that hypothesis. You know, you're right, I can't really see anything.
You know you can't.
Holy moly. All right, well, so we're going to talk a little bit about the clinical spectrum of what I consider the most fascinating disease that anybody in esophagology treats. Now, I put up this slide just to allow myself to say hello and to also thank Felice Schnoll-Sussman and Tom Watson for allowing me to do this, and to join all of you who have decided that this was important enough to get on airplanes and cars at a time that actually really has tried most of our souls. So I'm going to talk to you a little bit about the clinical spectrum of achalasia. You've actually seen the radiographic slide here, I think by about 3 speakers this morning, but no one has showed you Dr. Schnoll's bird beak slide that I stole from her. Now, when I was in training at Bowman Gray in Winston-Salem, where Joel was one of my teachers along with Don Castell, I was basically taught that achalasia was a very straightforward disease. You had no peristalsis and you had a high residual pressure. And if you didn't have those 2 things, you couldn't have achalasia until Joel convinced me that I needed to make my own perfusion catheter that was 11 millimeters in diameter and actually have manometry. And no, Dr. DeMeester, I didn't have that transnasally. I did it transorally, but Joel was nice enough to do it as well. And we showed that there were variants of achalasia in terms of relaxation. So talking about the clinical spectrum is really quite apropos. Now, to me, this is a disease with a functional abnormality at the esophagogastric junction that I call incomplete relaxation and opening, and esophageal contractions with the loss of normal peristalsis, and in many cases, contractile vigor. And ultimately, there is delayed transit through the esophageal body, excuse me, and esophagogastric junction delay. That's really the functional abnormality. And if you put those together, you can develop your own clinical spectrum, or at least how you might think there would be different presentations. Now, for me, the question every day in the clinic when I think about these patients, and I did borrow this slide from Dr. Schnoll, so thank you very much, is what you're seeing true achalasia, and is it really one disease with several presentations? Dr. Speckler just gave us a very erudite theory as to pathogenesis, but the presentations are quite varied. We have some where there's no doubt, and then others, let the buyer beware. Don't operate, don't dilate, don't do what you need until you're absolutely sure. And if you can't tell the difference from the cars, then I don't need to give the talk. So then the next question is, how common is the motility abnormality that we're talking about, or any motility abnormality that we're talking about? And for me, I always think back to the way things were once done and how they've evolved. But we think about achalasia as a disease with multiple clinical presentations. Well, if chest pain is really the presentation, the only symptom, non-cardiac chest pain, as in this study we did at Bowman Gray back in the 80s, achalasia is quite uncommon. Again, this was perfusion manometry, not even solid state yet, very early in a large series, but these were 910 patients with non-cardiac chest pain. Only 255 had a motility abnormality, and achalasia only in 2%. On the other hand, dysphagia, when that was the primary symptom, motility abnormalities are clearly much more common, achalasia 36%. So in the context of the symptoms that we see in this disease, yes, you do see chest pain, but I think it's rarely the only symptom and rarely the primary one. So when to suspect achalasia, and in my mind, make the diagnosis quickly, because as most of you know, this is often a diagnosis that is delayed for reasons that to me are unclear, but I guess I can understand it given the modern world of giving PPIs regardless of the symptoms. So solids greater than liquid dysphagia, often both. The classic heartburn, not typical of GERD, that's heartburn in between meals, burning or heartburn during a meal, regurgitation during a meal, right after a meal, and supine, chest pain, again, during a meal, slow eating, standing during a meal, walking to move food in the stomach, last person to finish the meal, other forms of people telling a story of dysphagia. People do wake up with halitosis, wake up with oral debris in the mouth. Even globus can be a presentation of achalasia in the literature. Recurrent pneumonias, probably from aspiration, exacerbation of asthma. There are reports of airway obstruction from a megaesophagus as the presentation of achalasia, case reports of a neck mass. And if you've not seen anyone who had a diagnosis of anorexia nervosa but actually had achalasia, you haven't lived. It's no fun, but it does happen. And then just general weight loss usually is not the only symptom, but certainly part of our thinking. And then in this day and age, anyone failing a PPI trial for an esophageal symptom should be potentially on the list of having achalasia. And by the way, I hope fewer of you than in the general medical population give empiric PPI trials for dysphagia as the primary symptom. Most of those people don't have GERD as the presentation. Now, the demographics are interesting. Any age, can be infant, can be 99 or 100. I think 99 is the oldest I've treated, 94 the oldest I've dilated, but 30 to 60-year-olds are the most common. Any gender or sex, depending upon the term you use today, and there's no ethnic or racial predominance. There's no geographic or regional predominance that anybody has determined. Twins have been reported to both have achalasia, and there are obviously congenital syndromes, and morbid obesity does not preclude the diagnosis. Most of us who do this every day have seen morbidly obese or very, very super high BMIs, to be politically correct, have achalasia, and it's real. Don't forget that there are secondary causes. They're rare. About 1 or 2% are the biggest series, not to be missed. Malignancies basically of any type, either local or infiltrated. There are paraneoplastic syndromes, a fair number of benign conditions associated with achalasia, like Parkinson's disease. The result of another intervention, someone showed, actually Joel did a picture of a lap band. That was probably secondary achalasia in that picture. And unfortunately, we do see achalasia after a fundoplication. The best reason to make sure they don't have a motility abnormality before they go. And I missed any discussion after John Lipham's lecture. Other mechanical issues are certainly associated with it. Now, the major secondary features of rapid weight loss, greater than 10% body weight over the last 6 months, rapid onset dysphagia in age over 55, are really not worth much these days, but academically, Harold Tucker's study from the Annals of Internal Medicine in 1978 is still quoted, even for lack of sensitivity. Now, a quick comment on the Eckhart score. Please remember, this is a score that was designed to assess treatment efficacy, not severity of disease. And while I believe that symptoms are probably still the best guide, at least in the first bit of post-treatment outcomes, the Eckhart score is really not a good way to assess achalasia severity and has not been validated for that purpose. It does put in perspective what the most common symptoms are: dysphagia, regurgitation, and retrosternal pain. Obviously, grading these and computing a score is potentially helpful, but it was meant to, or published to evaluate the efficacy of pneumatic dilatation, nothing else, despite how widely we use it. Now, diagnostically, we have multiple tools, and I'm going to review them briefly as part of this idea of a spectrum. Now, I think the endoscopic findings of achalasia are underappreciated. I think because many people use the esophagus as a conduit to the stomach, where I find very little pathology compared to what I find in the esophagus in my practice, there are endoscopic findings that we should be looking for very carefully. Obviously, retained food is easy. Most people don't miss that, or liquid after fasting. But excess saliva, I believe, is a soft and probably better than soft sign of poor emptying. You do enough upper endoscopy, you don't expect much saliva in the esophagus after an 8-hour fast. Dilatation of the esophagus is hard to grade, but nevertheless can be ascertained. And then the appearance of the gastroesophageal junction is actually potentially not diagnostic, but should increase your clinical suspicion. Now, these photos came from the GERD guidelines published a year ago, so that no one thinks that they're mine. Here's a picture of too much saliva in the esophagus and the GE junction in its puckered form that will result in slow passage of the endoscope and the classic pop. Here are some other features that one might think of as being suggestive of achalasia. Dilated esophagus with a fairly normal vascular pattern, food both at the GE junction and sticking to the wall of the esophagus, the vivacious, intense vascular pattern on the lower left, the so-called quote-unquote spastic thickening in the middle at the bottom, and then what you really can't see very well is a small diverticulum at the lower end of the esophagus here. Now, we've heard a lot about barium this morning. Joel's talk was excellent, and there will be very little repetition either by accident or by luck. But I think he emphasized, as did John Lipham, that a very good study by a good radiologist should not miss achalasia. A well-performed normal study will almost always eliminate it at Cornell because we have made a great deal of effort to get them to do swallows in a way that help us. And you've already heard of its value for hernias, paras, and other things. This is achalasia on a barium study. This is also achalasia on a barium study. It happens to be secondary with the tumor outlined with the white arrow, the bird beak, not classic, but close with the dark arrow. This is achalasia spastic. This is achalasia in the setting of a hiatal hernia. The bottom line is the spectrum is varied. You have to know what you're looking at and what you're looking for. And if you have no other good barium radiography, I agree with Dr. Richter that you can teach most radiologists how to do a time study, and you can interpret it yourself relatively easily. Now, the standard is still high-resolution manometry, but we accept 3 phenotypes. That means there is a spectrum on manometry. You have to know how to read it, and you have to know how to interpret it. Type 1, type 2, and the elusive type 3, which is not being discussed today as the 3 different phenotypes. And then the esophagogastric junction outlet obstruction dilemma, which creates a lot of debate amongst us daily and in conferences like this. One with hypercontractile features. You see an elevated IRP with a jackhammer, an EGJ with normal peristalsis, but if the time barium swallow is consistent, you might treat this like achalasia, although slowly, and then beware of the artifactual rise in the IRP. That's not achalasia. And you've already heard indirectly from Joel and from my introduction, you can have a normal IRP and have achalasia. We know about symptomatic EGJ outflow obstructions, absent peristalsis with a normal IRP, elevated IRP with jackhammer features, and elevated IRP with spasm, and occasionally DES with a normal IRP. You need a rapid drink challenge and a barium swallow to help. And then we have learned that manometry in patients on opiates is fraught with danger at every level and makes one have trouble. But these are all achalasia-like abnormalities. I'll remind you all to take a look at Dustin Carlson's article from AJG in 2016, looking at inter-rater agreement between all raters by esophageal motility diagnoses, Chicago 3 at that time. The kappa for achalasia type 1 was 0.82, type 2 0.77, and type 3 0.39. So the clinical spectrum between raters needs to be taken into account. You have to be comfortable with your own ability to read manometry. And then Dr. Carlson gave you a very elegant overview of FLIP. And this is the only FLIP slide I'm going to show, I believe, just to remind you that the variations in FLIP remain to be determined in terms of diagnosing as well as following the disease. So ultimately, is every EGJ outflow obstruction potentially achalasia? The answer is maybe, but between an HRM with a rapid drink challenge, multiple repetitive swallows, a timed swallow, and FLIP, one ought to be able to figure that out. So with that, I do thank, again, moderators and all of you for listening, and I look forward to any discussion. Thank you very much.
Great, thank you.
Thank you for that great talk, Phil. It's my pleasure to introduce next Dr. Abe Khan. He's the Associate Professor of Surgery at NYU Grossman School of Medicine and the Medical Director of the Esophageal Center. This is someone I work closely with on a daily basis as the Surgical Director of the Esophageal Center. Abe is passionate about esophageal diseases and really can pontificate about them for hours. I look forward to hearing his take on the optimal therapy for achalasia and EGJ outflow obstruction in 2021. We as surgeons love the slogans, Heller is stellar and make Heller great again, and I'd love to hear what the GI thoughts are on this. Welcome.
Okay, thank you very much, Dr. Damani. That was very kind, and thanks to the course organizers for inviting me today, and to AFS for really setting up this multidisciplinary conference. So my task was, as you mentioned, discussing treatment. Now that you've heard so much about achalasia and EGJ outflow obstruction, what is the optimal therapy? There's my disclosure. So I'll spend a couple minutes, not to belabor things too much, but really the importance of an accurate diagnosis for these conditions is very relevant in terms of what you're going to do with treatment. But I'll spend most of my talk on really the evidence that guides optimal therapy for achalasia and EGJ outflow obstruction. So you've heard a lot about Chicago classification version 4.0 just coming out this year. And high-resolution manometry does remain the standard tool to subtype achalasia based on the pattern, with the assumptions being that other diagnostic testing supports the diagnosis and pseudoachalasia is excluded. And sometimes it is very straightforward. You can get a conclusive achalasia pattern on esophageal high-resolution manometry with an elevated median IRP in at least one position, and then depending on the presence of panesophageal pressurization or premature swallows, you can really right there say the patient has type 1, 2, or 3 achalasia. Now, EGJ outflow obstruction before Chicago 4.0 was based on some peristalsis with an elevated IRP suggesting a potential poorly relaxing EGJ. Oh, whoa. There we go. So, and as we know, the natural history of going by Chicago 3.0 definition of EGJ-00 was that most of these patients do pretty well with conservative management. Only a small minority really went on to develop achalasia. In fact, sometimes the manometry pattern will really reverse to normal with simple maneuvers like sitting the patient upright. So we've known for quite some time now that EGJ outflow obstruction, at least by its historical definition, was a manometry pattern that was not necessarily clinically relevant. And certainly, even if you believe that it might be relevant, primary EGJ outflow obstruction may not be related to just inadequate LES smooth muscle relaxation. Now, to this point, when you're thinking about treatment evidence for EGJ outflow obstruction, most of the papers and the evidence have been based on this prior definition, and usually it's definitive achalasia treatments sometimes offered in carefully selected patients amongst a larger group. One recent example, actually, with a little bit larger group than some of the typical papers, was 55 poems done for symptomatic EGJ outflow obstruction, where the authors of the studies were deciding individually which of their patients should get definitive therapy. 94% of them had success based on Eckhart score at a mean of only 117 days, so not really followed out too long, and 66% of those patients had GERD by pH studies. So we need more long-term follow-up, certainly, on EGJ outflow obstruction. But now we also have Chicago 4.0, where it's a lot harder to make that diagnosis. And again, we're assuming a negative careful endoscopy here, but it's a very key point in Chicago 4.0 that a manometric diagnosis is always considered clinically inconclusive. And to get a clinically relevant conclusive diagnosis, you not only need stronger metrics on manometry to say that EGJ is poorly relaxing, but you also need clinically relevant symptoms, and you need at least one other investigation, such as time barium esophagram or FLIP, to support obstruction at the EGJ. Now you can see that algorithm there on the right, which comes out from the technical review associated with Chicago 4.0, where the authors really say as you go down that pathway, if you really don't have an abnormal time barium esophagram or FLIP, then you really have an inconclusive diagnosis of EGJ-OO, and you should refrain from definitive therapy of achalasia and consider repeat testing in a 6 to 12-month interval. Now, you may also run into the problem of inconclusive achalasia on manometry, and that could be having absent contractility with an IRP sort of towards the upper limit of normal in one or both positions, some peristalsis when you change position, or evidence of spasm and peristalsis and inconclusive type 3 achalasia. And then there's also the issue of opioids and how they can really affect the pattern of type 3 achalasia. And when you have an inconclusive situation, again, the suggestion is to do that time barium esophagram or FLIP to determine if definitive achalasia therapy is recommended. I won't belabor this because you've had a great lecture already on this. Different metrics have been used, specifically at the 5-minute point. And there's been a discussion already about the addition of a barium tablet to increase the diagnostic yield for achalasia and EGJ outflow obstruction. And then you also had a great lecture on FLIP technology, and specifically FLIP panometry, which is looking at the contractile response to distension and EGJ opening dynamics, both of which really can be important in attempting to support or not support an achalasia diagnosis. So if you look at that 687 patient study that Dr. Carlson went over earlier, really the 203 patients with normal EGJ opening is extremely impressive that 99% of them actually had normal EGJ outflow per manometry Chicago 4.0. So a normal EGJ opening on FLIP is very powerful to exclude EGJ achalasia physiology. Now, if you've still done all that and an inconclusive achalasia physiology assessment remains, what should you do? Now, medications have very limited evidence, and here with the suggestion to not really be definitive or at least do something that might have harm, Botox is often an option. It might even be an arbiter that if the patient does very well with Botox, perhaps you now believe that the patient should get upgraded later to a definitive therapy. Smaller dilations, not pneumatic, up to 20 millimeters, perhaps combined with injection, although there's no real data on that. And then the EsoFlip therapeutic balloon, small studies have shown benefit in achalasia patients, and at least theoretically, since you can kind of dilate in that gray zone of 21 to 29 millimeters, potentially there could be less risk of perforation compared to pneumatic dilation, but pneumatic dilation in the right hands has very low risk anyways, and we do need a little bit more data on that. Now, if you are confident that you do have achalasia physiology and your patient can take on the risks of the definitive procedures, what should they be offered? And that's where we're talking about three potential options: pneumatic dilation 30 to 40 millimeters, laparoscopic Heller myotomy with partial fundoplication, or POEM. So I'm going to go over some of the main studies really looking at comparative treatment options in achalasia. I feel obligated to discuss that European achalasia trial, which really started about 10 years ago or so. And about 5 years ago, there was the 5-year outcome data, and the success was pretty similar between pneumatic dilation and Heller myotomy by Eckhart score, quality of life, esophageal emptying, and LES pressure. An important point is that those pneumatic dilation patients were allowed 2 sets of dilations the first 2 years. 25% of them went on for another dilation performed after 2 years. And if you look at the treatment efficacy by subtype, they did quite similarly between type 1 and type 2, perhaps even better with pneumatic dilation with type 2, although probably not clinically relevant. And type 3 did better with Heller myotomy. So the conclusion of that study was that both could be offered as first-line treatment options for type 1 and 2 achalasia. And then there was the pneumatic dilation versus POEM study, which was a randomized 133-patient study where the treatment success was defined by a 2-year follow-up Eckhart score, and this certainly favored POEM. However, 16 of the pneumatic dilation patients only had 1 30-millimeter dilation, and the group overall was only allowed 1 30 and 1 35. Most of the patients had type 2 achalasia, and the pneumatic group had 1 perforation, 1 hospitalization with no serious events in the POEM group. And the POEM had more reflux esophagitis, 41% versus 7%. Moving on to the more recent Heller myotomy versus POEM study. Now, this was a 221-patient study, which was actually analyzed as a non-inferiority study, and POEM was non-inferior at 2 years if you were looking at Eckhart score. Most of these patients, again, had type 2 achalasia. And if you look at the 2-year GERD follow-up, in reflux esophagitis and PPI use, they were certainly higher with POEM. pH studies were done in a little bit more than half of the patients, and those were similar between the 2 groups. So around 2019, this meta-analysis came out, actually comparing treatments by subtype, and actually included a lot of those prior trials in over 1,500 achalasia patients. And the conclusion of that was that actually POEM was best for type 1 and type 3 achalasia, and the 3 options equivalent for type 2 achalasia. Around the same time, a meta-analysis came out looking specifically at GERD after treatment and comparing Heller myotomy to POEM, and by all metrics, esophagitis, pH, and symptoms, POEM had higher degrees, really, of GERD. The studies were heterogeneous without standardization, but that really led to the question in POEM patients, should there be a subset that should be considered for partial fundoplication afterwards? Now, since then, there have actually been 2 network meta-analyses encapsulating even more patients. One was published in Surgical Endoscopy in 2020. POEM and Heller have comparable efficacy and may increase treatment success compared to pneumatic dilation. And POEM may even have lower rates of serious adverse events compared to the other 2 options, but higher risk of GERD. The Lancet very recently came out with this statement: POEM and Heller myotomy, based on their network meta-analysis, should be the preferred treatment options for idiopathic achalasia, with pneumatic dilation performing worse and its role being less certain. And then we also have 2 society guidelines, ACG and ASGE. SAGES actually also came out with a guideline recently specifically for POEM, and are relatively similar recommendations to these here. ACG and ASGE both said that all 3 options are effective for type 1 and type 2 achalasia, with a preference for a tailored and longer myotomy for type 3 achalasia to really deal with those spastic contractions going up in the esophageal body. And there was a lot of mention of local expertise and even shared decision-making being relevant for this rare disease. So that's really led to these general recommendations, and I'm taking this from the Chicago group recently, where if you have conclusive type 1 or 2 achalasia, definitive treatment options really include all 3 options. If you have type 3 achalasia, a tailored and long myotomy is the preferred treatment. But what are some other pearls of treatment and some other sort of clinically relevant scenarios those of us that see achalasia run into? Well, I think overall for type 1 and type 3 achalasia, a multidisciplinary discussion, if relevant, is often important. You know, specifically for type 1 achalasia, patients that are progressive, perhaps untreated for many years. If you see that esophagram in the top left and you're a GI, if you talk to your surgeon, what is the confidence of success of a Heller myotomy with straightening there? You know, what do they think about that particular case and that particular esophagram? And then for type 3 patients overall, and I think specifically for type 2 patients where some of the diagnostic studies are suggesting spasm, I give an example there in the top right, that's a very high pressurization in terms of amplitudes that we typically don't see in classic type 2 achalasia. So could there be embedded spasm in there? Should you do other diagnostic studies, whether it's esophagram or flip, to really understand if you have to deal with spastic contractions with a long myotomy? And then what about this more recently described phenomenon called the blown out myotomy or BOM? Now what is this? This is a recently described recognized adverse event and pseudodiverticulum from a myotomy, either Heller or Poem. What is the mechanism? I think it's still being sorted out, but theoretically is due to wall strain in the area weakened by the myotomy, thought to be from either residual spastic contractility and or continued untreated outflow obstruction, really highlighting the importance of ensuring that complete EGJ disruption and the lack of having any spastic contractions left proximally. And I think this leads to the question overall is, should there be a thought of precision myotomy based on diagnostic studies? Now we talk a lot about long poem for type 3 achalasia, but should there be a consideration for limiting that poem to the EGJ for non-spastic achalasia? And we do have a couple outcome studies on that. One was actually just published in GIE from China, actually looking at 91 poems randomized. They all actually had type 2 achalasia to short. You can see the image there on the bottom right, quite a short myotomy versus standard poem. And they both had similar one-year success. All of them had pH studies, and there was actually less GERD in the short myotomy group. And then in terms of failed treatment, I think one of the highlights here is that you have to reassess carefully diagnostically. Is the failed treatment because the therapy was incomplete, or is there another physiologic process going on, such as reflux or a stricture? And then pneumatic dilation, Heller myotomy, and POEM can all be options for retreatment after an individual assessment. This is where I really think local expertise becomes important. And then as a last resort, in most cases, esophagectomy for surgically fit patients with megaesophagus failing other therapies. So in the future, I think further understanding of subtypes across the achalasia spectrum with our diagnostic tools may be very relevant, allowing for perhaps even more tailored treatments in this spectrum, designed really to minimize GERD risks as well as complications, and some of that esophageal remodeling and complications such as the BOM. So in conclusion, an accurate diagnosis of achalasia and primary EGJ outflow obstruction is paramount before deciding upon therapy. Subtyping achalasia guides evidence-based treatment decisions, and local expertise in a multidisciplinary approach, which fits very well with AFS, are often vital in optimally treating patients with achalasia and EGJ outflow obstruction. I want to thank our team at NYU. We're very fortunate to have a great collaboration between our surgery and GI teams, and a lot of presence here at the AFS meeting today, and thank you all for listening.
So the last part of this section is going to be something we actually did last year during the virtual American Foregut Society meeting, and it's called Meet the Press. It's going to emphasize Chicago classification. We've already introduced Peter Karillis. The second individual hosting this will be Roger Tatum. Roger is a surgeon, a professor of surgery at the University of Washington in Seattle, and also head of the GI division there. Roger, Peter. Go get it, King.
You can go if you want.
Thanks, Joel.
Yeah.
It's certainly a pleasure to be here. We know that we're all at stands between you and cocktails, so we're going to be brief. But this is Meet the Press, and our topic is indeed Chicago Classification 4.0.
We're going to have to come.
Now, I'm going to frame this around the press, and the press this year was a series of publications about this. This is the first paper that I'd like to address, and this is the main document. It's Esophageal Motility Disorders on High-Resolution Manometry, ECC version 4.0, and my discussant for this is going to be Dr. John Pandolfino. Now, Dr. Pandolfino, what is different about CC version 4.0?
Can I sit?
Yeah, you can sit. Saves time.
Yeah. I want to get everybody to the cocktail hour, so.
You can take a mask
So
off.
very quickly, the main differences obviously are, the protocol first of all, and that now it's expanded beyond 10 supine swallows. I'm just so used to wearing it. So. And I think, that's something that changing positions, adding some provocative swallows is definitely a big change. And then I think, of course, adding complementary testing to really focus on conclusive and inconclusive diagnoses. I would say that those are the main differences between 3.0 and 4.0.
So, John, what were the biggest problems with CC version 3.0, and how were those addressed?
I don't think I need this.
You don't need it, okay.
Thanks, though. Well, I think that the biggest problem was really the reliance on the IRP, to be quite honest. I think, the IRP in and of itself as a metric, you have to be very careful with. It shouldn't be thought of as a dichotomous line in the sand. It should have been thought of more as a logistic regression with a probability. So if your IRP is 35 and it persists in an upright position, it's probably real. But you can still have achalasia with an IRP of 10. So this heavy reliance on this was a really big problem, and ergo the EGJ outflow obstruction conundrum that was associated with that. I think that has been addressed now with the use of complementary tests. I think that was extremely important. I do think increasing the threshold for ineffective esophageal motility brought it back to some more clinical relevance, although, as we saw with the talk today on anti-reflux surgery and predicting dysphagia, it's still not a great tool to predict dysphagia post-operatively. But I think really the main thing that 4.0 tried to address really is the EGJ outflow obstruction and the introduction of symptoms, corroborating testing, and complementary confirmatory testing to make it a conclusive diagnosis.
Thank you, John. So one of the add-ons, so to speak, with CC version 4.0 was that the difficult issues were all addressed as technical reviews. And statements came out of these technical reviews, as well as findings that were incorporated into the protocol and into the whole concept of it all. Now, one of these technical reviews was obviously going to be about EGJ outflow obstruction. And I have here with us today one of the key authors of that, Dr. Carlson. So, Dusty, contrast what it takes to arrive at a clinically relevant conclusive diagnosis of EGJ-00 in CC4 versus CC3.
Yeah, so like John alluded to, in CC3, there was a lot of reliance on the IRP. In fact, really everything relied on the IRP, and if there was not peristalsis, it was achalasia. But if there was, and the IRP was elevated, that was EGJ outflow obstruction. Addressing that limitation was a big priority of CC4, and now it requires elevated IRP in two positions, both the supine and upright. Again, still not having peristalsis to meet a criteria for achalasia, but also bringing in intrabolus pressure, which should be elevated as evidence of outflow obstruction, bringing in the necessary symptoms that would support the presence of obstruction, and then perhaps most importantly, bringing in complementary testing, either an abnormal time-varying esophagram, abnormal flip, or even using pharmacologic provocation to actually reach a diagnosis of a conclusive, clinically relevant EG outflow obstruction.
And Dusty, you talked to us earlier about FLIP, and actually FLIP works its way into CC4.0 as one of the arbiters here. So how is EGJ obstruction diagnosed with FLIP?
Yeah, so I think, like we talked about earlier, and kind of borrowing on a similar slide, EGJ obstruction can be identified really by applying a series of two metrics that are part of the outcome of FLIP. First is using the EGJ distensibility index, but then also using the maximum EGJ diameter, the greatest diameter that's achieved at the EGJ. And by using the two together, this was kind of a scheme derived in part in response to overcome that reliance on the IRP with manometry, but with two metrics and when they're both consistently reduced, so a DI less than 2, a diameter less than 12, this is going to provide some confidence that there is reduced EGJ opening. But I think perhaps more importantly here is recognizing that on the other end of this flipped spectrum is that a normal EGJ opening, when the DI is more than 2 and the diameter is more than 16, that's going to be very strong to rule out obstruction. And in that scenario, it's unlikely that there is a clinically relevant or conclusive disorder of EGJ outflow. And further, I think we also included it when we looked at this and tried to validate this scheme looking at prediction of esophageal retention. You can see here that even when controlling for IRP and manometry, controlling for age, sex, and hiatal hernia, this scheme of flip and EGJ opening was very strongly predictive of abnormal retention on an esophagram, especially with that reduced EGJ opening category.
Great. Thank you very much. So the next topic we're going to cover, and for this I have the honor of actually asking the questions of Dr. Karillis himself, has to do with the esophagogastric junction outflow, barrier function rather. And this is very interesting because this is not yet fully defined, even now. And so my first question is, why isn't the EGJ barrier function yet fully defined in version 4? And can we expect that this will happen in the next iteration of the Chicago classification?
We haven't done 3D
Well,
5 years.
you know, you think about it, an esophageal manometry was kind of devised as a test to look at the barrier function of the lower esophageal sphincter, and yet that is the one thing that it has yet to succeed in doing, which is kind of amazing. And you thought that maybe with high-resolution manometry this would become simpler, but it didn't. So why didn't we incorporate it? Well, we did a technical review on it. We came up with some strong recommendations about how to assess the EGJ, but could really not come to any consensus about what that assessment meant and where you would get a conclusive diagnosis of anything. Hence, it's not in CC version 4.0. Will it be in 5.0? Judging by the way this went at 4.0, I would say probably not. But there is room to be hopeful.
Everybody has their marching orders, I guess. Well, with that being said then, what would you say is the state of the art in evaluating EGJ barrier function in 2021 without having this definitively set out for us?
Okay, so what can we say about the EGJ and what could we get consensus about? Well, we decided that you should score it during a period of quiet respiration, and you should look at it over 3 respiratory cycles, and you should, of course, measure the EGJ pressures relative to gastric pressure. And then the metric that got the most traction was this LES-CD separation, because it is indicative of hiatus hernia. So here you see none on the left, there's a 2-centimeter separation in the middle there, and there's a 4-centimeter separation on the right. So it was agreed upon to do it. It was agreed that CD0 means there's no hernia, CD4 means there is, but we couldn't get consensus on the middle ground. Some people looked at that and said that is not indicative of a hiatal hernia, and other people said it was. So although we said you should measure it, we couldn't decide where the cutoff was to call it hernia. It was decided that the respiratory inversion point is the point where you switch from an inspiratory increase to an inspiratory decrease. We agreed on what it was, we didn't agree on what it meant. And then with respect to morphology, we agreed that there are basically 3 morphologies. There's the LES or the CD superimposed on the LES, which is the 0 over there. We have the LES CD separation being greater than 1 centimeter and the RIP being between the two. And then we have a frank hiatal hernia where there's the greater than 1 separation and the the respiratory inversion point is proximal to the LES. So that there was agreement on. There was lots of discussion about the EGJ-CI, contractile index, and you see how that's computed on these three panels over here. But the problem with the literature is that everybody's thresholds for calling something indicative of impaired barrier function is different. So it's easy to say that the lower it is, the worse it is, but as far as getting any conclusive diagnosis, we're just not there yet.
Thank you. Well, hopefully there's looking to the future on that. Appreciate that answer.
And next, another technical review was done on the standard protocol. And this was authored by the group you see here, and the representative that we have to discuss this is Rina Yadlapati, except that she's not here. So I'm going to pose her a couple of questions. The first one is, Rina, you being in San Diego right now, why is it necessary or essential to standardize the HRM clinical protocol?
You know, I think to understand why it's necessary to have standardized the protocol for high-resolution manometry, we have to look back at history. And looking back at when high-resolution manometry was first introduced, experts from that time, such as yourself, often will liken the culture and the field to the Tower of Babel from Genesis. And if you all are familiar, that is where God gave humankind different tongues and languages to impede their ability to communicate and collaborate with one another. And similarly, when high-resolution manometry was adopted across labs around the world, there was not a standard protocol. Now, we know that to have normative thresholds and a diagnostic criteria, these can differ based on the position the patient is in, the number of swallows that are performed, the type of swallows. And so this was really quite problematic, where different protocols were being utilized by different labs around the world, which meant different types of interpretation, really no ability to have quality assurance and monitor outcomes, and it impeded the ability to work together and move the field forward. So over the years, performing 10 supine wet swallows has become somewhat of a norm. But we can appreciate that there can be misdiagnoses and borderline patterns with just these 10 supine alone. In fact, when we surveyed our group in 2019, the High Resolution Manometry International Working Group, it was clear that all of our labs were utilizing different protocols. So this was really the impetus to standardize the protocol that would be comprehensive, efficient, evidence-based, and this was really one of our top priorities in Chicago classification.
Well, thank you, Rina. And what are the key elements of CC 4.0 and why were they devised?
So I'll briefly walk you through the high-resolution manometry protocol that's recommended in the Chicago classification. This is the general text of the protocol, and if we take a closer look at it, the study will begin either in a supine or upright position. This is very important. The updated protocol really has flexibility. So you can start in either position, but it's very important that you include both in your protocol. So our lab begins in a supine position, so I'll present this protocol as such. So first, once the catheter is placed, there's an adaptation period, 3 deep breaths, and a baseline period. And this is really to ensure that your catheter has crossed the crural diaphragm, and so that you can assess anatomic landmarks and especially the esophagogastric junction. Then comes the 10 swallows, 5 milliliter wet swallows. And again, this is either in your supine or your upright position. This is to assess the primary esophageal motor pattern. Then also the multiple rapid swallow is included in the protocol. So this is the provocative maneuver where patients drink 2 to 3 cc's successively, repetitively, and the sequence can be repeated up to 3 times if needed. The primary purpose of this is to assess peristaltic reserve. We can also look at properties of lower esophageal sphincter relaxation and esophageal contractile activity during the multiple rapid swallow itself. Then we change positions, so you can go from supine to upright or upright to supine. And once you've had the adaptation period and baseline period again, you move into your five wet swallows. And this is an ability to reassess peristalsis and LES relaxation with position change. This is particularly important when we're considering a diagnosis of EGJ outflow obstruction, or if we had borderline or equivocal findings in the primary position. And then finally, the last part of the protocol is the rapid drink challenge, where the patient in an upright position drinks a large bolus. And this is an ability to assess LES relaxation in response to this provocation. And if you have impedance, also to assess bolus clearance. Now, there are some important things to keep in mind. If you have borderline findings, or if you suspected that there was a pathology that was not identified with the standard protocol, you can look to other maneuvers, solid test swallows, postprandial monitoring, pharmacologic provocation if you have it available. Also, in certain situations, you might look to supportive tests, which includes time barium esophagram with tablet, or the functional lumen imaging planimetry study, specifically if you're evaluating for EGJ outflow obstruction. So that's our standard high resolution manometry protocol. And I'll say that we implemented this in our lab 2 years ago. Generally, this protocol takes about 15 minutes and it's very well tolerated by our patients. If there's a patient that's a high aspiration risk, we might abbreviate the procedure. And we do recommend in the Chicago classification that if you have a conclusive type 1 or type 2 achalasia in your 10 primary wet swallows, you can consider abbreviating the protocol as well. I hope that's been helpful, and I hope everyone's having a wonderful AFS. Thank you.
Thank you, Irina.
Our next interview is also one that has been done virtually. Dave Katz couldn't be with us today, but he was able to join me for a virtual interview a few days ago, and so we're going to go ahead and play that for you now. As long as I can get this thing to work. Here we go.
Roger. That didn't look like him.
That's it. That was quick, right? Jesus.
I'm here with Dr. David Katzka, who's a professor of medicine in the Division of Gastroenterology at the Mayo Clinic in Rochester, Minnesota, and an expert in and author on the Chicago Classification version 4.0 Technical Review in Achalasia. So my first question for you is, what is different about the Chicago Classification version 4 diagnosis of achalasia? And further, is there the potential for defining further subtypes, say, for example, among the inconclusive categories, or what are more commonly termed the achalasia variants in the next version of Chicago Classification?
Thank you, Roger. This is a very important question. One important difference is that in type 3 achalasia, the definition has changed from no normal peristalsis to no evidence of peristalsis. This may appear a subtle point, but the elimination of any sequential pattern of esophageal contraction from the type 3 definition provides for a stricter understanding of the disease. To some degree, differences between Chicago versions 3 and 4 in defining achalasia also stem from global changes to version 4. That is, performing the study in both supine and sitting positions and encouraging the use of adjunctive testing for an unclear diagnosis of achalasia. For example, in version 4, an elevation of median IRP in either the supine or sitting position satisfies the criterion for LES dysfunction. In contrast, there must be absent peristalsis in both testing positions. As discrepant results in two-position testing may clarify or obfuscate findings, a section on inconclusive achalasia is included in version 4. For example, in a patient with absent peristalsis in the supine position, but peristaltic activity in the upright position, additional testing with time barium swallow or endoflip is required to establish the diagnosis. An important question asked by Roger is whether we can assign a specific achalasia subtype to this category. I suspect we will be able to in time, but with moderate heterogeneity in the manometric pattern of these patients involving the esophageal body and/or LES, we will need further information. Thus, a general theme differentiating versions 3 and 4 is a more comprehensive yet specific definition of achalasia, but with room to better classify patients with a diagnosis suggestive of, but not diagnostic of achalasia, utilizing these complementary tests.
Well, thank you. That's very helpful. So my second question is, there's a lot of overlap between type 3 achalasia and distal esophageal spasm. Is it possible these are really the same entity?
Yeah, that's another key question, Roger. What I'm going to do is just put up a summary slide of a little bit of what I'm going to talk about. And this question has both practical and etiologic implications. Manometrically, these diseases are two different diseases, as the sine qua non for achalasia is absent peristalsis with an elevated median IRP, whereas patients with DES spasm have some peristalsis and a normal IRP. On the other hand, both these diseases fall in the unique spectrum of neuronal disinhibitory disorders of the esophagus. Furthermore, anecdotal literature suggests that patients may transition from diffuse esophageal spasm to achalasia, as patients with type 3 achalasia may develop some normal peristalsis after treatment, therefore blurring the lines between these two entities. There is also data suggesting that in some patients, this ganglionitis progresses. DES and type 3 achalasia may also share common histologic features of thickened muscle, neuronal fibrosis, and loss of interstitial cells, Gahal. Thus, type 3 achalasia and DES may be a continuum of the same disease in some patients, whereas in others, DES remains static and distinct.
Great. Thank you so much for taking this time. We really appreciate it.
Thank you.
And take care. Thanks for joining.
My pleasure. Thank you.
Okay, now what?
All right. That's just the slide that he already displayed there. We'll move on to our final interview. And this concerns the review on ineffective esophageal motility. For that, I have Dr. Gayawali here with us, and I'm going to go ahead and hand this over to him.
Thank you.
You're welcome. And I'll ask our first question here. So, Prakash, through each iteration of the Chicago classification, the definition of ineffective esophageal motility has become more stringent. Why do you think this is so? And what are the implications that this has right now, ultimately, on the potential recommendations for treatment recommendations? Does this change how we practice?
This is an important question. The way to think about ineffective esophageal motility is that this is not a diagnosis. This is a pattern, a motor pattern that doesn't always signify disease. It has some associations with reflux disease, but it can be a normal variant, and it can be completely asymptomatic. And it has taken us 30 years to realize this. So let me explain. It all starts with Peter Krillis. So 30 years ago, or thereabouts, Peter reported with perfused manometry and barium studies that it took 30 millimeters of mercury of contraction amplitude in the esophagus to clear a bolus from the esophagus. And over the next decade, the assumption was that if you did not have this 30 millimeter contraction amplitude, maybe your bolus is not being transferred. Maybe that can explain dysphagia or some other symptoms. So people tried to increase contraction amplitude with prokinetics, did not work. And then the next step was opinion-based criteria that suggested that if you had many swallows with amplitudes below 30 or DCI below 450, maybe that is a disease, and maybe that can explain something. That also did not work, and we started finding out that some patients with these abnormal contraction patterns could actually improve their contraction if you challenge their esophagus. That's the concept of peristaltic reserve. And so finally, we are at the point where we now understand, based on data, that not all ineffective motility that we used to call ineffective motility is really ineffective, or not all patients have symptoms, and not all symptoms can be explained by this pattern. So where we are now with the current definition is that we are more stringent based on data, such that if you have extreme degrees of ineffective motility, then that can be associated with poor clearance of bolus in the context of reflux, and maybe poor clearance of bolus from ingested food, although the correlation with dysphagia is not great. So the implications now are that if somebody has ineffective motility according to the current version of Chicago classification, it is worth doing some additional provocative work to figure out if that makes any clinical sense. But treatment targeted at the ineffective motility still eludes us.
Thank you very much. The final question then is, what would you consider to be the state of the art for interpreting ineffective esophageal motility in 2021?
Funny you asked that question, because I actually have a slide to try and explain that. So the current criteria for ineffective esophageal motility, and this is based on data that became available in the last 5 to 7 years, is more than 70% ineffective swallows and or more than 50% failed swallows. And the spectrum of ineffective swallows includes not just low contraction vigor, less than 450 millimeters mercury per centimeter per second, but also the old fragmented peristalsis, where there were more than 5 centimeter breaks in the contraction peristaltic integrity, because it's clear that when there are long breaks, there can be bolus escape in the esophagus. And that's the criteria for ineffective motility now. And these are some of the consequences or scenarios where this pattern, this ineffective esophageal motility pattern, can be encountered. Now, criteria that do not fit this orange box criteria are considered inconclusive. And evidence of contraction reserve, lack of contraction reserve in provocative testing, or abnormal bolus transit can support a conclusion of ineffective esophageal motility. So these are some of the provocative maneuvers that could be performed based on what the patient has presented with. So in the reflux context, multiple rapid swallows. If the patient has dysphagia, rule out obstruction, look for latent obstruction with rapid drink challenge, and so on. And some of the other supportive tests that we have talked about extensively this afternoon could also be utilized here, the barium studies, flip studies, and so on in the right context. Now, prokinetics do not work. So we do not have a good means of making the patient better using these medicines. Normal variant does not need treatment. Asymptomatic pattern does not need treatment. If you determine that the IEM is seen in the context of abnormal reflux clearance, treating reflux may help. And if it is determined that the ineffective motility contributes to a transit symptom, these are some of the measures that could be undertaken.
Hypnosis.
Great. Thank you very much.
Well, thank you, and thank you to all the discussants. I think we've given you a flavor of CC4O, and I'd encourage you to dig up those technical reviews for a fuller understanding of it if you need it for the manometry lab. At this point, I'm going to turn over the podium back to the session moderators, Tanuja and Joel. And we have a little period for discussion for all of the talks.
How about getting a drink?
So we have a lot of experts up here. We don't want anything to happen.
We can answer those
precious
questions
stuff.
while we drink.
So we have some time for questions. If you come to the podium or come up to the microphones. Can't see anything. So we can see you.
Can't see who's asking. It's terrible.
So while we're waiting for the first question, I'll ask you, Abe, you mentioned BOM and the role we're recognizing in some of the failures post-POEM or Hellers, and you said we see it with both. Is there a higher incidence of BOM that we're seeing with Hellers because we're dividing both the longitudinal and circular muscles?
I personally don't know the answer to that question. I haven't seen enough to say that there's a higher incidence of one more than the other. I don't know if anybody else would comment on that.
Yeah, our data that looked at that tried to parse that out a little bit, and we did see it more frequently in Heller myotomy, and I think it was a combination of potentially 2 factors. I mean, one is that complete myotomy that involves both muscle layers, but also the fundoplasty, and perhaps providing some additional outflow obstruction that kind of contributes to the pathology there. And yeah, I'm doing some work with some of our engineers lately. We've actually been able to mechanically model that supports those 2 hit factors of both the complete myotomy and that added resistance at the EGJ that may contribute to BOM formation. But yeah, somewhat.
Fighting that battle between reflux control and potentially increasing the EGJ output.
With due respect, bomb's not new.
Bomb's not new.
Bomb's not new.
It's just more in the conversation.
They've just made a compilation of things to put it in perspective. But Joel taught me about bomb way back when I was, had black hair.
Oh my God.
It can happen, from any of these procedures when they're not technically perfect or you have complications afterwards.
You can't understand what's being
Yeah, it doesn't happen with pneumatic dilation, though.
I didn't say it did.
We've got a question, a microphone on the left, far left.
and the right as well.
Yeah, hi, John Rakowski from Buffalo. Just a quick question that probably would have been directed to the one panelist that's not here, but in terms of protocols, she mentioned that it's very well tolerated, high-resolution manometry in her lab, and I would say that in my lab it's probably not so well tolerated by a number of people. And they've asked about sedation or, can it be done after the EGD or whatever? So has there been any evidence to say that if you do use propofol or any other sort of benzos or anything to calm them down or put it in during the EGD or anything that it affects the outcome of the study?
We'll have John answer that one.
Sure. I'll tell you. It's not comfortable, and I don't think it's very well tolerated. People get through it in 15 minutes, but I think they're not happy. We do a lot. We're a referral center, so we do a lot of cases where people have come, they've had problems. They start to cry when you tell them they have to do another manometry. So we do it endoscopically and we place it. And yeah, if they're propofol or even conscious sedation, we just wait a while. And we did go back and look and see if that made a difference, in terms of what we would diagnose and what they eventually were diagnosed with, and comparisons with their older manometry, and then even the comparison with the flip. And it really doesn't change things all that much. I think you can get a pretty good diagnosis if you have to do it that way. But still, I think you should try to avoid doing it while they're getting opioids or benzos. I think it does affect the IRP a little bit, the latency a little bit, and you would prefer to do that. But if you had to and the patient was really adamant that they weren't going to do it that way and you needed to get the information, I think you can get it pretty well. But yeah, those things are horrible.
Hello, Steve Clayton, Wake Forest University. My question is for Dr. Stuart Speckler. I found his lecture very intriguing. When I was at the University of South Florida with Joel, we did a study looking at patients that had both the EGD and histologic evidence of EOE, and we looked at they also had concomitant high-resolution manometries, looking to see if we could identify some sort of manometric phenotype associated with EOE. Overall, we looked at 29 patients, and we really didn't see any kind of characteristic phenotype. We did notice that there was increased intrabolus pressure in patients with the fibrostenotic subtype. And our average IRP in the 29 patients was 6. And one patient had IEM, and I think one patient had esophagogastric junction outflow obstruction as their final manometric diagnosis by Chicago 3. So we really didn't see a whole lot of patients with the manometric diagnosis of achalasia. I wanted to know how often you're seeing that. 2, should we be biopsying our patients with achalasia to see if they have esophageal eosinophilia? And then 3, is there a certain, what are these patient demographics that you're seeing with, this esophageal eosinophilia and achalasia manometric, or manometric findings of achalasia?
No, thank you for that. I think you make an excellent point that you can see the entire spectrum of motility abnormalities in patients with eosinophilic esophagitis. Now, if you look just at achalasia from Dr. Gwali's experience, and to find 8% with achalasia, that's very high, and another 8% had EGJ outflow or similar types of things. We think that there could be a form of eosinophilic esophagitis, for example, that has primarily mucosal, muscular involvement rather than mucosal. Now, we can only identify mucosal because that's, when we do endoscopy, we don't have access to the muscular layer. But if you look a priori at what these eosinophils make, they make all kinds of things that could either relax the muscle or contract the muscle. So a priori, you couldn't predict what it's going to do to have eosinophils in your muscular layer. So I think we're very early in our understanding of this process. There's no doubt, in my mind anyway, that some patients with eosinophilic esophagitis have achalasia that does resolve when you get rid of the eosinophils for whatever reason. I still don't know how common that is. I mean, that it does happen, whether it's very frequent in achalasia or not, that we still have to determine.
Stu, to follow up on that, you show Savarino's case report with the conversion with the steroids. You've been talking about this for the last couple of years. Have you run across other literature showing that the steroids treatment or anything for EOE actually converted them from a true achalasia pattern to a
there are other anecdotal reports, but nobody has done this in any kind of systematic fashion that we've found. If you look in some review articles on achalasia, on eosinophilic esophagitis, they talk about achalasia as a disease that you have to eliminate because that's a disease that can have eosinophils. Well, why would achalasia have eosinophils? That doesn't strike me as being a reason to be having eosinophils. It's not like hypereosinophilic syndrome. Okay, that could be confused with the EOE. So again, we're early in our understanding of this disease, what it does, and this new thing about mast cells. I mean, that's a whole new aspect of eosinophilic esophagitis in general. We've underappreciated how important mast cells are in that disease. And you can have people who respond to PPIs or steroids, you get rid of all their eosinophils, they still have symptoms, and they may have mast cells, and it's been shown that they may have increased mast cells, even though the eosinophils have gone away with your treatment.
We had someone microphone on the left, or did they?
I think Felice. Sorry,
Felice. Or
I think she's left. So
Felice?
Fitting, I'll ask the last question before drinks. I've never really thought about this, but seeing as we have so many experts up there, I feel compelled to do so. We know that achalasia doesn't start on Monday, right? It's a spectrum over time. I'm wondering, now that we actually have treatments that are really efficacious, let's say POEM for achalasia amongst the other treatments, would there be a reason to tell patients that have, let's say, EGJ alveolar obstruction or one of these inconclusive studies that remain symptomatic, should we actually be telling our patients to maybe come back if they stay symptomatic in a decade? Because maybe they actually truly have achalasia, and then we'll make a definitive diagnosis and treat them. And right now, we don't actually have enough conclusive evidence to do something invasive, but you know what? Let's not lose you. Let's not have someone tell you you're crazy or it's all, all in your head, because maybe they actually do have achalasia. So as I'm sitting here and we have this mastermind of people up there, would that be something reasonable to tell our patients?
10 years would be a bit long.
Yeah.
3.
I think you run the gamut of tests with these people, and that's why we say you try to get to a conclusive diagnosis. And as John alluded to, even then, sometimes you don't, and you're still on the fence. And if you want to do something, that's what Botox is for.
That's not exactly where I put it, but okay.
Well, I would go further to make the comment that, first of all, I think that makes a lot of sense what you're saying. And, obviously, as what we've been talking about throughout today illustrates, we elucidate more ways to work this up over time. Our definitions are changing over time a little bit as well as we learn more. So 2 years, 3 years from now, we may know more. We may be able to get to that diagnosis a different way. So I think maybe for that reason alone, the answer is yes. If the patient is still having symptoms, why wouldn't we encourage them to do that?
Primo non nocere, everybody. And if you can't figure out what they have, don't do something to them. Because the reality is that 10% of them fail when you absolutely know what they have. And that's what the data are. And none of you on this panel can refute that, because that's what's in the literature. POEM is not 100% effective, neither is a Heller, nor is a PD. And my mentor taught us all, do the least you can do first. So PD, 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 if you're in doubt. Don't cut. Don't use a knife. Sorry, surgeons.
I can't leave this group because we're not talking about it in the rest of the meeting. But we talk about GERD and we talk about POEMS, and we now know that there's been a number of cases of Barrett's reported, and we now know there's been at least well-documented case from Hopkins of adenocarcinoma reported. So I'm fearful. I'm not going to have to worry about it because I'm going to be retired fairly soon sometime. That's true. But I think this younger generation is going to see GERD and its complications in the POEMS patients. So what does this group think about that idea, and what are they doing to prevent it? What are they doing to prevent it? Because we know we've got a nice study just recently about the scleroderma experience at Phoenix, the recent scleroderma experience. And remember, when you do a POEMS, you convert them from one disease, achalasia, to a second disease, scleroderma without Raynaud's. And in that scleroderma experience from the Mayo Phoenix, there were Barrett's, a number of Barrett's, and adenocarcinoma. So what are we doing? What are we thinking about? Because POEMS is everywhere. 5 years ago, there were 2 centers doing POEMS in the state of Florida. Now there's about 10 or 12.
Yeah. But Joel, you know, if you think about it, all of our invasive treatments for achalasia, the aim is to destroy esophageal function in one way or another. POEM just happens to be more effective at it than most of them, and it's longer. One of the reasons we are so excited about the possibility that there might be an allergy-induced form of this disease is maybe we can finally have a medical therapy to actually reverse it rather than just palliate it as we've been doing. But I think your concerns are well justified.
Prakash, how concerned are you in St. Louis?
Well, I think the issue there is, again, this conclusive versus inconclusive. And unfortunately, Chicago 3.0 probably contributed to this excessive use of POEM for EGJ outflow obstruction. I think 4.0 will rectify some of it. And you know, I think that is part of the concern here. There is a lot of interest among patients for a POEM, and sometimes you have to push back a little bit. That's what we're trying to do, and you know, be conclusive, manage only patients who have conclusive outflow obstruction, and watch the rest. And I think Felice's point is well taken, that in some instances, watch and wait is an acceptable option for these patients.
You know, I'd add something to that, which is just that we heard a lot of talk about the importance of the hiatus as an anti-reflux barrier. And that's real. The hiatus is 80% of the anti-reflux barrier. You're not disrupting that when you do a POEM. You are disrupting that when you do a lap Heller. So yes, there's no anti-reflux component to it, but you have left intact the anatomical aspect of the anti-reflux barrier. So I think you're going to have less of a problem. I think you can also calibrate the extent of the POEM that you do with intraoperative measurements so that you minimize the amount of wall disruption that you're doing. And frankly, we haven't had that much a problem with reflux. We've done, I don't know, what is it, John, 300-400 POEMs at this point?
400 or 500, yeah.
500.
Well, but I mean, I think, you know, like you said, I mean, they are predisposed to severe reflux. They have a pathophysiology associated with severe acid burden and reflux burden, so you have to follow these people closely.
Well, and
bring them
remember,
all
GERD
back.
is a 20-year disease.
Yeah.
You get a student with GERD, you know, a medical student with GERD, they're not going to have Barrett's. So
No, and I bring my patients back at least every 3 years, and I follow them. And, you know, I tell them this is the disease you have forever. We didn't cure you, and we have to watch it. And, you know, obviously, most people don't want to take a PPI the rest of their life. And there are some people who will stop it, and they'll come in with a bad stricture, and they learn their lesson, they go back on it. But there are, I think we've had maybe 2 or 3 people that have actually required an anti-reflux procedure in our POEM group. I know Eric's here, he probably knows it better than me, but, you know, and they did fine after they had that operation. But I think you have to follow them closely.
Yeah, and there's plenty of reflux after lap Hellers, too.
I mean, the problem is that these people who get treated and they're told they're fine, and they come back 15 years later and their esophagus is the size of my head. You know, and no one's like evaluated them or talked to them, and they've been having regurgitation every day, dysphagia, but they just get used to it, you know, and they don't care. And then they come back with a mega esophagus, and then you're in a bad situation for those people. So I think, achalasia, we don't cure them. We have to follow them. And, when I work with Eric, I say, Eric's going to take care of you now, but I'm going to follow you, for pretty much the rest of your life. And I bring them back every 3 years, and I do an endoscopy.
What about the surgical colleagues? What are you all doing?
I'm a little biased in that I don't do POIM. I do lap myotomy with toupee fundoplication. I think with respect to the hiatus and the discussion about that, first of all, having a hiatal hernia and achalasia simultaneously is far from unheard of. We see that fairly often, and we fix it when we're in there. That's very common, actually. Ironically, I had a guy with intrathoracic stomach and achalasia who was 92 years old. I put in a J-tube. I didn't do anything more about that. But in any case, also when you create the toupee fundoplication, you're anchoring that to the diaphragm as well, and of course you're anchoring it, to the lateral esophageal wall. So you are keeping it there, and you're maintaining the presence of the EGJ below the diaphragm with that, with relative success. So I think there are some potential advantages of that. I do acknowledge that the studies in POIM are quite good. But I will say that the experiences that people have had are variable in terms of how much reflux they have. And there's maybe the jury's still out.
Point about the angle of hiss, I think, as you said, when you do a toupee fundoplication, you are kind of recreating, if anything, an enhanced angle of hiss. So I do think a fundoplication is an important part, but in all fairness, we don't routinely bring the lab Heller and fundo patients for endoscopy, even though the data shows that even that population has reflux when you actually study them. So I think it's a commitment, regardless of the procedure, that these patients need to be followed.
But the hernia is an important thing. I think Dan Lister's talk, where he talked about doing a good exam. I mean, we see these people who have a hernia, and they do have achalasia. I mean, they're definitely there, and those people in our practice tend to get Heller myotomy with a hernia repair and a partial. So I think that is definitely important to recognize that is there. But as I mentioned, I watch these people like a hawk. And, there are also the opportunities of endoscopic therapies. If someone doesn't have a hernia, you're pretty confident. There is some literature out there looking at TIF. I think we might have done one of those in an achalasia patient. I'm not exactly sure, but that could potentially be an option too. But you have to watch these people, and if they do break through and you can't treat them medically, they get an anti-reflux procedure. And it's amazing how well they do. The scleroderma patients, we've been sending a lot of these people for partial fundoplications, and especially our lung transplant group, and these people do okay. They don't get dysphagia. They're pretty happy that their reflux is gone, and so this idea that we shouldn't be doing it in that patient population, that was dogma, and now we're doing them a lot. So just be vigilant. That's what I would say.
Great.